Our next speaker this morning, we're very pleased to have a speaker with us who has not spoken for us before, but is becoming another integral part of our team, Dr. Veronica Hirsch Reinshagen, who is a neuropathologist. So a neuropathologist is someone who looks at the brain after someone has passed away and tries to determine what changes are present in the brain, like those plaques and tangles that Dr. DeMarco discussed, and determine how that results in the diseases that we're seeing in our patients. So she will be discussing the ranges of neuropathologies we see in different types of dementia. Thank you.
Thank you, Dr. Foti, and thank you to the organizing committee for giving me the opportunity to present today. I'm very excited about it. So I will start sharing my screen here. So I'll be talking about the brain changes that we see in different dementia types. I have no conflicts of interest to declare. So one thing that I always get asked about when my friends are a new acquaintance and they ask me, what do you do for work? And I say, I'm a neuropathologist. And the answer to that is, you're a what? And so just to explain a little bit more about what I do, here's my more famous colleague, Dr. Quincy, but just like him, I use a microscope, although I have a bit of a more modern version, and very thin sections of brain tissue that I stain with different types of stains to evaluate the histological changes in the brain that explain the cause of dementia in a patient during life. So dementia is a clinical diagnosis based on a combination of symptoms, signs, and maybe some additional test types. The most common cause of this clinical syndrome of dementia in adult people are neurodegenerative diseases. And so that word gets thrown around a lot, and what neurodegenerative diseases mean is a progressive and to date unstoppable loss of a particular brain cell type, which are neurons. And this leads to what we call atrophy or shrinkage of the brain tissue. There is also accumulation of abnormal proteins in these conditions, and the type of protein that accumulates is actually specifically correlated to the dementia cause. And so here I have an example of what a normal brain looks like when we look at it from the side versus one with neurodegeneration. And if I invite you to do my job with me, we will see that a normal brain, these folds here are called gyri. And in a normal brain, these gyri or folds are closely opposed to one another. And if you were imagine looking just at the surface of the brain, it would have more of a cobblestone sort of surface. In neurodegeneration, on the other hand, because neurons are dying and being lost, we see that these gyri are thinned out and that there is a lot of space between them. These changes can also be seen on imaging. Now, if we have a cross-section of the brain and we look at it sort of from the front, and we compare again normal with a case of a patient that had neurodegeneration, a neurodegenerative disease during life, we will see again this sort of space between the gyri. We will see that the ventricles, which hold this cerebrospinal fluid that Dr. DeMarco was talking about, are enlarged. This is because as tissue gets lost, there is more fluid filling up the skull. And there's also loss of this white substance here underneath the cortex, which is the white matter. So if you compare this area here, for example, with this one, you will see that there is loss of white matter. And these white matters are the tracts that connect different parts of the brain with each other and with the rest of the nervous system. So if pathological diagnosis of dementia occurs after death, why is it important to perform? And I think a good answer to that question is highlighted in this study, which was published earlier this year, where they evaluated more than 2,000 patients who had a clinical diagnosis of Alzheimer's disease and had postmortem neuropathological evaluation. What they found was that the vast majority, 80% of patients that had been diagnosed with Alzheimer's disease clinically, indeed had the pathological changes of Alzheimer's disease. There were two more groups, though, each of approximately 10%. One group where there was no, the correlation wasn't as straightforward. There was about 10% where the patients had a diagnosis of Alzheimer's disease during life, but at autopsy, they were found to have no Alzheimer's pathology and were found to have other types of pathology. Conversely, another 10% of these patients had a diagnosis of dementia that was not clinically diagnosed as Alzheimer's type, and on pathology, they had Alzheimer's, a neuropathological change. So to answer the question of the prior slide, neuropathological evaluation is needed to refine diagnostic tools to make better research studies and in the end understand and treat neurodegenerative diseases. And I think biomarkers, both imaging and blood and or CSF biomarkers will help refine these categories during life as well. Now, Alzheimer's disease is the most common of the neurodegenerative diseases causing dementia. This is again a little bit of a repetition of my 2 slides ago. A few points that I want to make. So on the left, we have a section of a normal brain, and on the right, we have one with Alzheimer's. One thing that I want to point out is, again, there is significant atrophy here of the cortex. We see how much space there is when normally there's very little. Deep nuclei here, such as the thalamus, for example, are really not that affected in Alzheimer's disease. And the area that is most affected in Alzheimer's disease and where the neuronal loss actually starts is here. So this is the medial part of the temporal lobe, which houses the hippocampus. And the hippocampus is the structure that is responsible for memory. And this is why patients with Alzheimer's disease have such problems with memory. And now if I invite you to do again a job with me, we will get a thin section here of the hippocampus, and we will stain it with a stain that's called a silver stain, which was used by Alois Alzheimer more than 100 years ago to describe the pathology of Alzheimer's disease. And we will look down the microscope. So this is what I see on a low power section of the hippocampus in a normal person. And it's not really relevant what structures exactly we're looking at, but if I ask you what color this all is, it's a nice sort of homogeneous gray. Here there are some blood vessels, but other than that, it looks relatively homogeneous. Now, if I ask you to compare that to a hippocampus of a patient with Alzheimer's disease, you will probably tell me that it's riddled here with spots and dots, and that's exactly the pathology that Alzheimer's identified and that we see in these patients. Now we're going to zoom in on the microscope, and we're going to take a look at one of these areas here. We're going to zoom in this part. So in a normal hippocampus, we have here neurons, which have sort of a triangular shape. Here's the nucleus, the nucleolus, the cytoplasm, and the rest is the background neuropil. If I ask you to compare that to a case of Alzheimer's disease, you will tell me that there are differences. Two are the main differences. One are these conglomerates of sort of lines and dots in a rounded conformation. Some of these have a center that looks darker, and these are what we call plaques. So these are the amyloid plaques that you have been hearing from Dr. Chung and Dr. DeMarco. And these are made of A beta peptide. The other abnormality that we see is if you compare this neuron here with one on the normal hippocampus, you will see that it has these flame-shaped inclusions in its cytoplasm, and these are what we call tangles. So here's a bit of a schematic to highlight the changes again. Amyloid plaques are composed of A beta protein, which, as Dr. Chung showed, is actually a fragment of a larger protein. A beta protein is made in our brain every day, and it's a normal process. What happens in Alzheimer's disease, and we don't quite understand why this is that it accumulates and forms these amyloid plaques, which we think are detrimental. The other thing about these amyloid plaques is that they are specific for Alzheimer's. No other neurodegenerative diseases have these senile neuritic plaques that I showed you. Neurofibrillary tangles, on the other hand, which are the intracellular abnormalities that I showed you, those flame-shaped inclusions, are composed of a tau protein. Tau protein is part of the scaffold of the cell and the transport system within the cell. And in Alzheimer's disease, it gets abnormally processed and it accumulates and it shuts down the normal transport within neurons. Now, the thing with tau and neurofibrillary tangles is that it can be found in other neurodegenerative diseases. It's not specific for Alzheimer's. And the fact that it forms part of the normal scaffold and transport function within the neuron explains why it increases non-specifically as a biomarker in any condition that affects the brain. So as Dr. Hackon showed initially, there is imaging of amyloid as a potential biomarker for Alzheimer's disease, with people who have normal cognition being amyloid negative, patients with Alzheimer's disease showing a lot of amyloid in their brain. And then there is this sort of middle group here where patients with normal cognition can be amyloid positive. And this is because, as I said, A beta gets generated every day. With age, it is normal to accumulate some degree of amyloid, but it's the severe accumulation and the co-accumulation with tau that marks Alzheimer's pathology. So if we have to have these markers, it would be fantastic if for diagnosis of specific neurodegenerative diseases. The problem is, and what we see is that a patient with dementia during life very rarely has only one pathology. So only in this population-based study, only 10% of patients that were diagnosed with clinical Alzheimer's disease during life showed a single type of pathology, either Alzheimer's disease, vascular pathology, or other neurodegenerative pathology. The vast majority of these patients actually have combinations of pathologies. And we know that the other pathologies that co-occur with plaques and tangles also have effects on cognition, and we don't quite know how each one of these contributes to the overall cognitive impairment. Here, I will show you two examples of these pathologies that we see co-occurring with Alzheimer's disease. One are Lewy bodies. Here again is a normal section. Here are pigmented neurons with that sort of brown pigment in their cytoplasm. And here are Lewy bodies. So you can see how the brown pigment here, it gets pushed to the side by an inclusion, a cytoplasmic inclusion that's pink, and it almost, you can see it has a halo here around it. This is in another type of neuron again. Here it's the nucleus, that's the cytoplasm, and you can see that pink inclusion in the cytoplasm. This rounded pink inclusion. And you can see how it's a little bit different from what I showed you regarding plaques and tangles. So Lewy bodies are frequently found as co-pathology in Alzheimer's disease on its own. Lewy bodies usually underlie Parkinson's disease.
2 minutes.
Okay. Vascular pathology is another frequent co-pathology in Alzheimer's disease, and this has to do, and hypertension can induce these changes. So here's a normal vessel in white matter with a thin vessel wall and blood inside. I have a stain that shows me the axons, so the connections, the tracts between different brain types, and this deep blue shows me that this is normal and healthy tract. In a patient with Alzheimer's disease, you can see how the vessel wall has thickened. And if I do my stain for these axons and these connections, you can see that it's much paler. And this tells me that there has been loss of axons and their sheaths in this area. How much of this is because I'm losing neurons or the patient lost neurons in other parts of the brain, or how much this is because the vessel is not working properly, we don't know. So in summary, the most common cause of adult dementia are neurodegenerative diseases, and within this category, Alzheimer's is by far the most common. Frequently, other pathologies coexist when we do neuropathological evaluation of brains, and to date, maybe this will change with development of biomarkers, but to date, postmortem evaluation of the brain is the only way to confirm the type, severity, and distribution of these conditions, and to provide a definite cause of dementia during life. And with that, I thank you for your attention, and I'll give it back to Dr. Foti.